So yeah, I guess what we could do, because there are a few people that registered that haven't logged on yet, but I guess what we could do is just get started. It's going out on Facebook, so there might be some people joining us on Facebook, and obviously it's going to be recorded as well, so we might as well get cracking.
Yeah, definitely. Sounds good.
I think, Matt, come a bit closer to your microphone. I don't think that picked up your mic then.
Okay, how's that?
That's better.
Okay, good.
So I guess just to recap from last time, we discussed kind of what pain is, potentially some of the things that can cause pain. So we spoke a little bit about posture and biomechanics. We spoke a little about central sensitization. Mm-hmm. Really, what I want to do in this session, there was two things I really want to do. One is, try and put ourselves in the position of someone that's in pain, someone who, perhaps they've been to see their doctor and their doctor has just said, well, here's some painkillers. If it doesn't get better, come back in a couple of weeks. And then they've come back a couple of weeks later and they said, well, you need to go and see a physio, or you need to go and see a specialist. And they go off and see this person and they're getting treatment, but nothing's improving. In fact, a lot of the time they don't even know what's wrong with them.
Yeah.
So again, I know it's obviously quite a big topic to discuss, and I really hope some people do jump on, because I really want people to ask us some direct questions tonight, so we can help people with specific issues. But if you were to put yourself in someone in that position, what would kind of be your main advice to those kind of people?
Yeah, well, it's very common, isn't it, that that people don't really know what's going on, and I think sometimes that's because they, when you're in pain, one of the things that happens when you're in pain is that your cortisol levels go up, and that's your stress hormone. And one of the functions of cortisol is to essentially wipe your memory, so you don't remember the stress so much. And that has a function in certain areas like hunting, and if you think of primitive times, and then childbirth would be another time where you've got to go back and do the same thing, but the pain was severe, perhaps. So the cortisol wipes the memory. So when we go into a manual therapist or a doctor or a surgeon's office in pain, then what often happens is we don't really hear what they're saying, partly because, it's another language quite often. And depending on the skill of the therapists and how good their interpersonal skills are and their ability to communicate, then, quite frequently I see patients that really have no idea what's going on. And so I think the first thing is quite often to explain what you're finding, or what the X-ray report means, or what the MRI report means, because, as I say, one of the challenges of medical interactions is that, of course, there is a whole new language, which is the kind of medical language, and often these are polysyllabic Greek or Latin words, which, when you use them on a daily basis, they feel like common language, but when people start throwing around certain terms and you're in this stress response state anyway, and you get out of the room and you can't really remember what was said, then that leaves you in quite a vulnerable feeling position, let's say. So I think, that's probably the first thing, is to, if you've got these kinds of reports, get someone to explain them to you. So if you're the patient with the report, and let's say you're going to see your doctor or your physiotherapist, then I think to get an explanation for what these things mean and the implications of them as well, because often there's terms that are used within these kinds of reports, like degeneration, or I don't know, like stress fracture and this kind of thing. And it's important to understand that, these things are not necessarily symptomatic. So, you can have a stress fracture in your spine. It doesn't actually cause any pain, and it may be an incidental finding, but it can cause pain as well. So, it's always a case for the therapist that they have to match up the radiological findings with the symptoms. And if they don't match, then of course then it's pointing away from that finding and to something else causing the pain. So yeah, I think definitely, getting a bit of background information and making sure you're comfortable with where you're at, with what's been provided already is important. But I think another challenge for patients and for therapists as well is that the model that we use for healthcare in the UK and in the West in general is one where it's a very short duration assessment or treatment. And for something as complex as a human body or a human being, I just don't think that therapists can make an effective diagnosis in the short times that they're given. So quite often they throw out a few ideas and a working diagnosis or a kind of best guess or a hypothesis as to what might be going on. But the reality is that they don't really know. And so some of that uncertainty probably comes across to the patient. And I think that can leave the patient quite confused and somewhat bewildered. And so there's that element to it as well. And I think that's perhaps why a lot of people do end up in a persistent pain state, is that there just isn't really the time to give the attention to detail. And like we discussed in the last podcast that we did, or interview, was that there's really so many factors that can contribute and often do contribute to a pain picture. So it's not just mechanics, but it can be emotions, and it can be hydration, it can be nutrition, it can be sleep, and the list goes exercise. The list kind of goes on, and it's not any one of those things that's driving the pain. It's the contributing kind of summation of all of those things. So I think, again, if you get people that are specialists in musculoskeletal medicine, but they don't understand those other factors, then you can often get a suboptimal result by seeing someone like that, and you go away feeling like no one can help you. So there's lots of factors, I think, that can contribute.
So there's a few things I kind of heard you say there. One was, if you're someone who perhaps has been and had some scans done, so MRIs, X-rays, whatever it might be, and often, obviously, you often get a report come with it.
Yeah.
And, I'd imagine most people in that position would read the report and just think, what the hell does that mean?
Mm-hmm. Mm-hmm.
So really what you're saying is, look, what you need to do is go back and say to the person, look, I've got the report, but what does it actually mean?
Yeah.
And what does that word mean? What does spondylolisthesis mean? I don't know what that is.
Yeah.
And not to feel kind of, feel silly because you don't understand these words. I mean, I know I get reports from clients, and there'll be 2 or 3 words nearly in every report. And I think, what's that word mean? I don't even know what that word means. And when I look it up, it's just they've used a different word that I would use for the same thing.
Yeah.
With probably another 6 syllables on it for the same thing.
That's it.
So,
yeah.
I guess what I'm getting your suggestion is for people to ask more questions.
Yeah. I think that's definitely important for the reasons that I said, and you've just espoused. Is the complexity of the language. It really is like learning a new language when you learn medicine, because these are just different things.
It's like learning Latin.
Well, it is exactly that. But you're not normally in a fit state to really understand what the person's explaining to you when it's being explained. So another good option is to have someone go with you. If you're in pain, have someone go with you, a friend, a colleague, a neighbor, to go and listen to what the therapist is saying, because they're likely to remember it better than you will. That would be another tip. But also the language that's used on these reports, because it's easy for us to talk about a slippage of a vertebrae or a herniation of a disc or degeneration in a joint, those kinds of things. And that's everyday language to us. We don't think much about saying that to a patient, but to a patient whose body it is, that's frightening to hear that you've got degeneration. They think this is like a one-way street, it's a downward hill, and everything's gonna fall apart, and I'm gonna need, let's say, a hip replacement or a shoulder replacement or knee replacement, whatever it is. So the point is that the human brain, and this is quite well documented in evolutionary psychology, the human brain is set up to actually catastrophize a little bit, to project the worst case scenario as a survival mechanism. And the simple sort of analogy that's often given is that if you were to go out onto the savannah and there's a bush over there, you've got to imagine that there could be a lion behind the bush, because if you don't, and you go too near to that bush, you could get ambushed and, you know, literally pounced upon by a predator. So you've got to be thinking about the worst case scenario. The problem is that then translates to our pain and other aspects of our life, which is why we love soap operas, because it's always bringing up worst case scenarios. But, you know, so the headache always, one of the first things people will think if it doesn't go, you know, fairly rapidly is this could be a brain tumor. You know, everyone does it. It's not that you're a hypochondriac. That's just a natural human state, unless you're an experienced headache sufferer and you know what causes it, you know. And so when pain is new for you, it's the first time experience that you've had low back pain or neck pain or whatever it is, then I think that's another time that it's it's useful to I suppose, you know, do what you can to have other people to bounce these ideas off, you know, and that may be a friendly therapist, it may be, like I say, a partner or a friend or whoever to come along, so they listen in and can ask the right questions. Because again, to the individual, you know, a diagnosis of degenerative disc disease can sound quite almost fatalistic. It's like, that's the way I'm going, and this is really bad. Basically, I'm going to be a kind of disabled by this, you know.
But then we know that, you know, degenerative discs and things like that are almost everybody these days, but not everybody's in pain, right?
Absolutely, yeah. So it seems that it's almost a universal that people have degenerative discs. It's just a matter of whether or not they happen to be symptomatic or not. And the other thing is that the discs can heal themselves, you know. So it's not a case. So, you know, the whole body is healing itself the whole time. I was just teaching today and talking to the group about osteophytes, which is bone spurs, you know, and so they were saying, well, can a bone spur be reabsorbed? And I was saying, well, yeah, in theory, of course it can, because the bones are turning over at a rate of almost completely every 6 to 8 weeks. That's why a fracture can heal in 6 to 8 weeks, you know, because you're turning over the bone. So, you know, the reason a bone spur forms is normally because there's aberrant movement at a given area, normally some kind of segmental instability or an excessive range of motion because perhaps a joint capsule is too lax. There's various reasons for it. But if you can stabilize that area to minimize those aberrant stresses, then what that means is that you're not got the stimulus for that bone spur to grow, and therefore, you know, if you're successful in stabilizing it, then as the bone remodels and reshapes, that bone spur is likely to decrease. Yeah.
So of course, bone spurs, in my experience, you know, most medical professionals would suggest surgery almost immediately.
Well, the interesting thing is that most people, again, have bone spurs from the age of about 16 onwards. You can find bone spurs, you know, to a greater or lesser degree through the spine. It's just whether or not it's pressing on something pain sensitive. And they tend not to press on something pain sensitive until, you know, either you have, you know, let's say perhaps an accident, or you have excessive load through a given area. Like, you know, a classic example would be Johnny Wilkinson, the rugby player, who's constantly taking these big hits through his shoulder, and it creates bone spurs in his neck. So something quite extreme like that for a younger person is what's likely to bring that on as a symptomatic thing. But generally, they don't tend to get symptomatic till you're older. And the challenge is that, of course, when they become symptomatic, then typically the symptoms are pain, but they can press on a nerve and not cause pain, but cause pins and needles or numbness or something like that. But so if there's pain present, the challenge then is that the pain tends to inhibit the muscles. Let's say it's in the neck, they inhibit the muscles that stabilize the neck. And so now you've kind of compounded the issue, because generally that bone spur is forming because there's a degree of instability at a segment in the spine. So it is a challenge to manage. And that's why, you know, I think a lot of people would think that, yes, surgery is the only option. But if it's managed effectively, some potentially with pain medications, but also with effective exercise and lifestyle advice, then you can decrease the pain, get to a point where you can start to activate the muscles that stabilize that segment of the spine, and then you can progress from there. And theoretically, again, the bone spur should reabsorb gradually. So I would certainly say that it's feasible. It's just whether or not you've got the persistence and the focus to commit to a program, and whether or not you've got a skilled enough practitioner to work with to do that. Yeah.
I want to go back to something you said earlier as well, Matt, because I think it's quite important. Because again, what I tend to see a lot of people who approach me personally, not professionally, that are in pain, my view is that their mindset probably isn't quite right in terms of understanding how they're going to get a solution to their problem. And you touched on it earlier, and when you were saying about, if you go and see a doctor or a therapist, they don't really have long enough to really find out what's going on. And I had someone contact me this week. He was on a course that I did last week for tennis coaches, and he obviously had an idea of my level of knowledge from the day. And he emailed me and said, I'd love to come and spend a couple of hours with you. I've got this problem and that problem. I've got this problem and that problem. And what I want to do is this. And I'm thinking, wow, and you want me to do that in 2 hours? And I had to kind of explain to him, well, it's probably going to take me 4 to 5 hours just to assess you. Probably a similar time to design your program, and at least a couple of hours to show you how to do the program. If you've got anything you might kind of add to that so that people kind of understand that concept.
Yeah, absolutely. So, one of the things that is becoming clear in the pain science, or pain neuroscience as it's sometimes called, is that when pain is persistent, almost invariably there are beliefs contributing to that. There's emotions contributing to it. There can be gut issues contributing to it. And there's a whole range of different associated, let's say, disorders or dysfunctions in the body. So things like irritable bowel syndrome, things like painful periods or dysmenorrhea, all kinds of kind of conditions like fibromyalgia or chronic fatigue, TMJ dysfunction. There's a whole list of things that seem to contribute towards the potentiality for pain. And some of these things are subclinical, and some of them are clearly symptomatic. So you can have relatively subclinical irritable bowel. Or
Matt, when you say subclinical, you mean?
Subclinical meaning that it hasn't reached a point where the patient feels they need to go to the doctor. Let's say every time they eat a given food, might be beans or something, they bloat, okay? And then next day they notice they've got a bit of diarrhea. Well, that's like a low-grade irritable bowel, but it's not sufficient. Maybe they're not in sufficient pain that they go and speak to the doctor, and they just know to manage it by avoiding beans. But they, maybe it's their favorite food, so they still eat beans quite regularly, right? So the point is that that's a kind of it's not at a clinical level where they're under medication and under the sort of auspices of a doctor to treat it. And same with the TMJ, you can certainly get a clicking jaw and it not be particularly symptomatic, but that's a sign of dysfunction. You can certainly get tension in the jaw, which you might not notice is there, but your partner might tell you, well, you're grinding your teeth at night, or your dentist may say you're grinding your teeth because they're looking all blanched or sort of flattened down from where you've been grinding them. But you might maybe none the wiser because you don't have any symptoms. Okay, so that's a kind of subclinical TMJ problem. But anything that's creating what we call afferent or sensory drives from the TMJ that are out of the ordinary can be driving sensitization through the cord, into the spinal cord, into the central nervous system. Now, of course, it's more likely if there's pain there that you will get this sensitization. But the point is that multiple low-grade inputs from just multiple suboptimal or subclinical situations can, again, summate to create a propensity to feel pain and a lower pain threshold, and also the perpetuation of pain after the original tissue injury is gone. So you know, when you take that sort of, and this is just like a in a nutshell version, of course, because they're just a few examples. But you really need to be screening for all of those things if you're working with someone in pain. Otherwise, you may be missing the drivers or the perpetuators of the pain. So, well, how do you do that in a 20-minute or a 30-minute session, or you know, for a lot of doctors, a 5-minute session? So most manual therapists spend no more than, you know, 20 or 30 minutes with their client, and sometimes it'll be longer. But even so, you know, I often give the analogy of working with a car, because obviously everyone knows a car is quite a complex system of systems. And, you know, if someone said to you, I can give your car a full service and MOT in the next half an hour, come back in 30 minutes and I'll charge you 50 quid. You'd look at them and go, this is a cowboy, right? You go, I can't leave my car with someone like that. That can't be right, okay? Because it's way too complex for that. But we're infinitely more complex than the car. So the point is that if we're infinitely more complex than the car, how can anyone, any sort of thoughtful therapist, really think that they can get to the root cause and really help someone in 30 minutes? So now, I'm not saying that therapists are being silly. What I'm saying is that there's a system that needs change. And the system at the minute is that we're trying to condense time down, and, you know, it's all about sort of the economics of it. But the reality is that actually it's not working for us, because when you go to a short treatment approach, which is the standards, and a short diagnostic time, etc., then you get mistakes and you get over focus on the symptomatic area. So if someone's got back pain, the focus goes straight into the back without looking at the ankles, the knees, the hips, the jaw, the neck, you know, everything else in the kinematic chain. And then, of course, everything else in terms of the visceral health, the organ health, everything else in terms of the emotional health. You know, there's so many factors, as I say, that contribute, that really the model, I think, has to change, because what we know is it's not working. So we know that musculoskeletal pain is on the rise in spite of increased physiotherapy, increased manual therapy, increased orthopedic surgeries, and so on. So we've got more and more and more of the therapies, but more and more and more of the pain. So we must be somehow doing something wrong, you know. And yeah.
So again, what I'm getting from what you've just said, there's two things really. One, therapists just don't have enough time in an appointment to really find out what's going on.
Yeah.
And coupled with that, they're not really looking at enough systems in the body to actually be able to help.
Yeah, I'd say so. You know, and it's not that they don't know about the systems, it's just that they don't have time to look at them, and or maybe they might feel a little uncomfortable. So a physical therapist is not particularly highly trained to deal with digestive issues. Obviously, they need to recognize them, but in terms of what to do about them, where they probably would refer out to a nutritionist, or, you know, to the gastroenterologist or to the doctor if they felt it was an infectious situation. So, you know, and the same with emotions. They're not particularly trained to work with emotions, but, you know, so might refer to the psychiatrist or whatever. So then you get this kind of, there's nothing wrong with that notion, because of course you're dealing with specialists. So a psychiatrist is going to be, you know, obviously very well informed of how to work with people's emotions and have a lot of clinical experience with that. The problem is they may not know much about, let's say, disc injury and the prognosis for disc injury in the low back. And then, you know, the nutritionist probably knows almost nothing about disc injury and doesn't know anything about psychiatry, or very little about psychiatry. So, you know, you have a situation where it's very disjointed and the patient feels like they're perhaps being pulled from pillar to post by well-meaning therapists. And, you know, unfortunately, as is evident, the system doesn't work. So I'm not sort of trying to, you know, call for a revolution and say that we need to get rid of these people. I'm just saying that, you know, somewhere in the training, we need to open out and not become so specialized. And this is part of the problem with academia, is that it tends to focus you down and down and down and down onto a narrower and narrower point until, you do a PhD about, whatever it might be, a specific gene sequence in mice that's related to, baldness or something. And it's so specific, so it's that notion that you get to know more and more about less and less until you know everything about nothing. So you're so focused on the baldness in mice that you've got no idea what's going on with the mice's feet or with the mice's liver or the mice's tail, or, it's just, about their baldness and that's it. And that's part of the challenge with the academic approach, is this narrowness. So the challenge that needs to be met now is to create more of an holistic approach, or an integrated approach, or one of the terms that's being used more now is a multimodal approach. So looking at a person's situation from multiple modalities, multiple different angles.
So I guess the takeaway for people watching this that are in pain is that possibly one of the reasons why they're not getting the answers or they're not getting the results is because whoever's helping them is probably only focusing on the musculoskeletal system.
Mm-hmm.
They're not looking at all the other factors you mentioned. They're not looking at what they're eating, what time they're going to bed.
Mm-hmm.
They're not looking at their emotions. They're not looking at their beliefs.
Yeah.
They're just looking at the body as a system of pulleys and levers, and that's probably why they're not getting the results. Would that be fair?
Yeah, I think, obviously some people will respond to a pulleys and levers type approach. That's for sure. And a bit of reassurance that goes with that through seeing a therapist. And also, I think a lot of therapists are aware that sleep's important, and they are aware that nutrition's important. But, as you and I know, to make lifestyle changes is much more challenging, and there's much more to it than just saying, oh, you should eat less gluten and you should eat more organic meats. You can tell people that, and that will work for the occasional person, but you actually need to have certain strategies and techniques to help people to make behavioral changes. So it's all well and good knowing that they should sleep more, or knowing that anxiety is a factor with pain or whatever, but you need to have techniques to work with that. And at the minute, those techniques are generally lacking. There are some people obviously that have developed techniques, work with these techniques and are integrating them into their practice, but they tend to be the exception rather than the rule.
And I guess the other thing to be aware of with those kind of things, certainly my experience of working with clients, is it takes time to coach someone through that process. It's not going to happen in a half an hour or an hour session here and there. It's an ongoing process of going step by step.
Yes, absolutely. Yeah. And, one of the things is that, of course, the most profound emotions that tend to affect people tend to be the things that they bury the deepest. And so, when you are working with a client for half an hour at a time, you often can't get to that kind of depth of discussion, let's say, because there's always that introductory period, and then there's always the kind of matter at hand. And then if you've only got half an hour, well, you're already closing and off they go again. But when you can work with people for longer periods, and you can develop more of a relationship with them, and you can gradually work your way down through the onion layers, as it were, to what's really bothering the client. And so, that helps you to build a relationship, helps you to get deeper and to be more effective in making change again for them.
So I guess another thing...
and when I say making change for them, it's really Go on. Sorry, I got a delay.
Yeah, sorry, I lost you for a moment then. I think it's the internet connection on my end. No, I was just going to say, again, for people that are in pain, it's kind of important to understand that it's not a therapist's job to fix you.
Yeah.
But it's a therapist's job to coach and support you so that you can learn how to heal yourself.
Absolutely, yeah. And that's what I was just amending to what I said in the previous sentence, because I think I said something about to get you better or something like that. And I didn't really mean it like that. What I meant was to give you the tools to get yourself better. And so, you know, that's really key. Like you say, the key for us is to empower the patient so that they feel that they understand what's going on. They have tools to help themselves not only get better, but prevent it from coming back. Yeah, you know, that they're not being treated like children, essentially, because you know, when you do that, then of course they won't take responsibility for themselves. So quite frequently that kind of, we talked about it last time, but you know, quite often the medical profession takes on the kind of parenting role, and the patient therefore takes on the child role, but that doesn't foster a responsibility taking attitude. So, and unfortunately, most treatment is exactly that. It's a treat. So if you treat a patient, then you're treating them, right? It's a treat. And so, you know, another word for treating someone is to spoil them, right? And if you spoil someone, you ruin them. So, you know, that's
yeah. And I
kind
guess
of a harsh reality.
I guess what we've been talking about kind of leads on nicely to my next question, and it's, if you can describe what's the difference between a symptom-centered approach compared to a client-centered approach.
Yeah, sure. So obviously a symptom-centered approach is as it states, that the symptoms are the focus. A client-centered approach is much more looking at you know, what the goals and ambitions are of the client, rather than looking at trying to get rid of their symptoms. And you know, I had a bit of a discussion with someone the other day who's a pain neuroscientist, and you know, I was just making the point that the problem with pain neuroscience is that it's called pain neuroscience. You know, it should really be called performance neuroscience or health neuroscience, because when the focus is pain, then you know, first of all, it doesn't really tell you much about what came before the pain. It's only like, well, how do we manage the pain? What do we do with the pain now that the pain is here? But also, it suggests that the pain is the only focus. And so that is like a kind of symptom-centered approach. So what we really need to do is have a person-centered approach. But you know, again, I was talking with Paul the other day, Paul Check, who obviously we both trained with, and he was saying that it needs to be person-centered, but it also needs to be therapist-led. And the point there, we'll come back to person-centered in a moment, but the point there is that if the therapist isn't living the life that they are suggesting to the client, in other words, if they're saying you should eat healthily and you should drink water and you should go to bed on time, you should exercise, and the therapist themselves isn't doing that, then they can't authentically lead. And so it's really important that it's patient-centered, but that there's a practitioner role modeling that occurs. Okay, so that was a key point that he made. I thought it was just worth bringing up there. But when it's patient-centered, essentially, you know, this is what we do in the check system. We don't focus on the pain. Obviously, we want to know about it. We want to know how it came on, etc., and we'll assess around the painful area. But we're not just interested in that. We'll assess the whole body and all the systems of the body, irrespective of what the patient's coming to us for. And then also, one of the things we will assess is what is their dream, what's their goal, what's their ambition, so that we can focus them beyond the pain. You know, one of the biggest challenges for people that are in pain is that their primary goal is to get out of pain. And that's not actually a good goal. A much better goal is to have a performance-based goal. And of course, you know, you'd want the pain to go, and the pain will typically go the more you move towards optimal function and optimal health. Again, as Paul Check says, you know, health and disease cannot coexist in the same body. Okay. And so if we can keep building health and keep building function and keep building performance, then the pain will go. And, you know, that's a slightly simplistic view of things, but it's got a strong air of realism to it as well.
Yeah, so I guess, you know, another takeaway message there is that, you know, don't think the rehab's finished when the pain has gone, or as soon as the pain has gone.
Absolutely. And this is, you know, something I've been trying to conveyed to various sort of professional groups for many years now that, you know, we've known at least since 1996 that when someone with back pain has, you know, they're 10 weeks beyond the pain going, and the muscles that get inhibited by the pain, they're still inhibited. Okay, so, you know, the point is, if your focus is to get someone out of pain, but not to rehabilitate the muscles, then that's problem number one. But what we also know is that when someone's had persistent pain, that those same muscles start to atrophy and get what's called fatty infiltration. So, you know, where the muscle once was, fat is appearing within the muscle compartment. So not only do we want to get that muscle activated and firing again, which requires rehabilitation exercises, but we need to create exercise loading and, you know, what we would call acute exercise variables, which stimulate a hypertrophy response. So essentially it's a training response that helps to rebuild the muscle back to its original size or potentially beyond it, so that you are back to full function, not just out of pain. Because, you know, if you're out of pain and you go back and, let's say, you know, play a game of rugby or a game of basketball or something with that muscle not firing, well, now you've got a problem. You're much more vulnerable to re-injury. And this is why with most injuries, the biggest risk factor for back pain is a history of back pain. The biggest risk factor for hamstring strain, which is the most common sports injury, is a history of hamstring strain. And that's really because, in my view, in many cases, what's happening is the symptoms are being treated, but not the cause. And so, you know, if you don't treat the cause, then of course, the moment the pain's gone, you go back to play, and boom, it happens again. So yeah, definitely, we need to look beyond the pain. That's for sure.
And you know, when you're talking about re-injury, I mean, it might not be playing rugby. It might be something very simple like picking up your child or picking up a relatively light box. You know, doesn't have to, or it might just be something that you do continuously that's kind of low level. But if you're doing something continuously every day, you know, if you're on the phone like this all day, every day, you know, potentially that could be a problem, right?
Yeah, absolutely. Yeah, and there's, you know, I don't want to get too contentious, but there's a bit of a misreading of the literature that's out there at the moment, which suggests that general exercise is as good as specific rehabilitation exercise. And again, that is based on symptoms, not based on long-term outcomes. And so, you know, you might have been told by a well-meaning therapist that, oh, you know, just get back to playing tennis or get back to your running or get back to your sport, whatever it is. That's as good for your back as anything else. Well, you know, that's not likely to be true based on the research that I just discussed. So you're much better to go through a rehabilitation process, because, you know, what we're talking about here is statistics that show, well, if I play tennis, does that reduce my pain as much as if I do my rehab exercises? And does that reduce my pain as much as if I went to see a manual therapist? And what they find when they assess those three things is that there's not a statistically significant difference between the three. But that's because the focus is on pain. It's not on function. So the point is, you should be doing all three. But it makes sense to see the therapist, do the rehab, and then play the tennis in that sequence. So we can be pragmatic about it, but each of those things contributes. So, yeah. So
my next question, I think we've touched on it a little bit already, but what kind of considerations should people in pain make when choosing the right professional to go and see?
Yeah. Okay. Well, I mean, obviously that's a difficult one. Well, one of the sort of early realizations that I think, quite fortunate to have in my career is that I wouldn't recommend a specific profession per se. I think it's really down to the individual within that profession. So you can get excellent physiotherapists and terrible physiotherapists, excellent osteopaths and terrible osteopaths, and same with chiropractors, massage therapists. You know, you get people that are totally into it and dedicate themselves to it, people that are just doing it as a means to an end. So, you know, I think obviously word of mouth is one way to do it. But I think, if you listen to this presentation and you listen to the previous presentation that we did, you'd want to hear similar language. You'd want to hear people talking about exercises. You want to hear them talking about nutrition and lifestyle. So, and if you're looking at their website, you want to be seeing that kind of thing. So, of course, what Leigh and I are trained in is the check approach. And of course, that is an holistic approach. It's corrective, holistic exercise kinesiology. Someone who's check trained should be able to handle all of these things and work effectively with you on all of these things. But there's lots of professions that have the capacity to work in a very similar way to the way we work as check practitioners. So, you'll find naturopathic osteopaths, for example. So they are osteopaths that have good background in nutrition and in psychology. So they're more likely to have a rounded approach than someone who doesn't have the naturopathic background. But it doesn't specifically mean that, because, of course, everyone gets their own interests and does postgraduate training once they're qualified. So I think probably the best way to do it would be to look at the websites and the literature and see whether they are talking broadly in holistic and integrated terms, and in empowering terms. If they're talking about treatment, that's more of a concern to me than if they're talking about coaching, let's do exercise program, let's do lifestyle work, etc., then that to me is someone that sounds like they're on it and they'd be good to work with.
Very good. So I guess just to summarize a few things that I've got from you so far, because one of the things I think is really important is the mindset. If you're in pain, I think the mindset tends to be, as I've said before, okay, I'll go and see someone and they're going to fix me, and it's only going to be a few sessions and I want to spend as little money as possible.
Mm-hmm.
Whereas I think, what we're saying tonight is actually you need more of a holistic approach. You need to think about more than just being treated. You probably need to think about doing some exercise. You probably need to be looking at your diet, your lifestyle in general, your sleep. And you probably need to be looking more long-term and looking to build strength and function within the body, not just to get out of pain. Otherwise, the pain's probably going to come back.
Yeah, I agree.
So,
yeah, absolutely.
So what I'd kind of like to discuss next really is, I guess, the system that we use. And, if you could explain to people what the 1, 2, 3, 4 model is that we use to help people.
Yeah, for sure. Well, so first of all, I think just to touch on what you started out with there, particularly in the UK, we're used to getting free healthcare. Of course, not strictly free because we pay our taxes to fund it, but the point is that we do have that kind of mentality that we have some kind of, let's say we deserve a certain amount of healthcare and we should be looked after. And what that tends to breed outside of the NHS is people looking for cheap treatment, because normally it's free. If someone suddenly has to pay, let's say, £250 an hour for someone, that seems extreme, given the fact that we don't normally have to pay for our doctor or perhaps for our physio or whatever. Okay, so but I think it's all about perspective and context, and very frequently what we do is we prize possessions a lot more than we do ourselves, and the challenge is that when you lose your health, then nothing else really matters. But you can't buy health, and that's another challenge. So that said, of course, what you can do is you can invest in health, and you can invest time and potentially some finances. And I often go back to that car analogy because we live in a scientific materialist society. Then we tend to value both science and materials. So we value our houses, we value our cars, etc. And so we pay out whatever it might be per month on our mortgage, normally at least hundreds, if not thousands of pounds. We pay out on our cars to get them fixed and keep them running. And if you add it up, it is thousands of pounds per year typically that everyone's paying on their car. They'll buy a new car for many thousands of pounds. They'll buy a new computer for hundreds or thousands of pounds, you know. So we place a lot of value on the materials, and then we try and get our back fixed for 25 quid, you know. And it's just a bit inverted the way we should be thinking, because your most precious asset is yourself. So, you know, to lead back to the 1, 2, 3, 4 approach that you were asking about, or suggesting that we go through, the 1, 2, 3, 4 approach is essentially a kind of stepwise plan where you start out with your one love or your one legacy or the one thing you want to achieve with your life. So essentially it's your life's purpose. You know, what is that? And that can be broken down as well. So it doesn't have to be, you know, tell me it now and that's it forever. It can be both changed, but also broken down into smaller goals and smaller dreams and so on. But the idea is that, you know, when you have a dream, you haven't got time for a nightmare. So if you can focus on the dream, it creates a positive focus and it takes you beyond the pain. And so that's where you start. You've got to kind of chart your course so you know where you're headed. Because again, you know, one of those phrases that we hear from time to time, if you don't know where you're getting, any path will get you there. So you need to have a focus at some point in the future. This is what I want to achieve. And that becomes your one love. So then you move on to the 2, which is the 2 forces. And the 2 forces are the fundamental forces of life, which, you know, it doesn't really matter what culture you look at. There's the kind of representation of them somewhere there in the mythology. So it could be sometimes represented as good and evil, or as chaos and order, or as yin and yang, as male and female, light and dark. You know, these are the fundamental forces in our lives. And so what we mean by consider the 2 forces or balance the 2 forces is to say, well, okay, the yang side, the male side, masculine side to life, which is associated with heat and light and dryness and inflammation and movement, that's one side. Then you've got the yin side, which is the kind of nurturing, the nutritional, the wet, the dark, and so on. That's the other side. And so when you look metaphorically at your life, how much are you exposing yourself to light versus how much you're exposing yourself to dark? How much are you exposing yourself to hydration versus to dehydration? How much to exercise versus to rest? Okay, and so you look at those balances, and what you typically find is, particularly in pain patients or patients with health conditions, is that they've got too much on the yang male movement inflammation side going on. Too much light, too much activity, not enough rest, not enough nutrition, not enough nurturing, not enough darkness, etc. You know, so what it helps the patient to do is to analyze where they're at in a very generic way and say, okay, so I've got an imbalance here. So I actually need more rest. I need more downtime. I need more water. I need more sustenance and nutrition. And so it helps them to sort of prioritize where to focus their interventions, let's say. So that's the getting the balance between the 2. And that's where a coach can come in really handy. In fact, for both of those stages, but a coach especially can be handy with that stage, because they can turn those kind of more metaphorical notions of yin and yang, the 2 forces, into, well, what does that mean for me on a daily basis? And they can make suggestions for coaching changes. So then the next step is the 3 choices. And the 3 choices are essentially, you can make an optimal choice, a suboptimal choice, or you can be indifferent. And so the optimal choice, of course, is, basically the function of these 3 choices is to really act as a kind of time machine in a way, to say, okay, so we know you've got too much yang in your life. Here's some yin things you can do to balance. Now, if you don't follow those suggestions, let's project a year into the future. How are things going to look? Well, I'm going to be more yang. I'm going to be more inflamed. I'm going to be more dry. I'm going to be more exhausted from all of the activity and movement and work and exposure to light and so on and so forth. So, okay, now let's imagine if you got more yin, more, quiet time, more nurturing, more hydration, etc., into your life, then how would things look in a year's time? And you look and you think, well, actually, I'd be feeling much better. I'd have more energy. I'd be more relaxed. I'd have less pain, less inflammation. And so you can see, okay, so that's the positive. That's what you want to focus on. So what's the negative? What's the opposite of that? So the opposite is to not follow that program. Okay. And so if you're not following that program, then like you say, you're still going to be in pain. So we kind of went through that projection. And then you've got the kind of indifferent, maybe do a bit, maybe not do it all, maybe cut out gluten, but I'm not going to stop eating bread because I like bread, so I'll cut out gluten and everything else. Or I'll do my exercise program, but instead of doing it three times a week or 4 times a week, like my therapist said, I'll do it once a week and maybe sometimes once every 2 weeks. So it's a little bit like, oh, I'm going to do it, but I'm not fully committed. And, so the point is that you put in some effort, but you don't actually get the results. So it's really, that's almost the most frustrating and the worst of the three. So, once you can put yourself through that mind exercise, that thought experiment, then you can see, well, there's only really one choice that makes any sense. And then the number 4, so been 1, 2, 3, 4, number 4 is to say, so which of these 4 doctors do I need to consult the most? Is it Dr. Diet? Is it Dr. Quiet? Is it Dr. Movement, or is it Dr. Happiness? And they're the last 4 doctors you'll ever need. That's the concept. And so, of course, you might need to consult all 4 of them, but typically there'll probably be a chief doctor that you want to go and consult. It might be Dr. Quiet. It's quite a common one that needs to be consulted. Often Dr. Happiness is one that needs to be consulted. And, of course, Dr. Diet. And Dr. Movement. I mean, obviously it depends on the individual, but often people are moving a lot. They might not be doing the right kind of movement. They're racing around from appointment to appointment, sitting, going to meetings, but they're not actually moving in what we might call, a functional movement way. So they're not going through full ranges of motion with their joints and loading their muscles effectively and getting their cardiovascular system exercised. So certainly a lot of people do need some more doctor movement, but quite often their priority is to get more downtime, more sleep, more quality in the foods that they're eating, and also to really think about what their life actually means, what their life is actually about, what's the purpose for it, and what is it that makes them happy? What can they build into their life that gives them a happy feeling and makes them feel alive? And so, then again, there's sort of metaphorical doctors that you consult with, and then you use that to inform the coaching program. So that's the 4 doctors, and the 1, 2, 3, 4 approach.
Okay, so just to kind of summarize for people out there that are in pain and they're not getting the answers, I think for a lot of people, it will need a change of mindset, that, the way that you're going to get a long-term result or even any result is to not think of it as if it's someone else's responsibility to get out of pain, but you need to find someone who understands different systems of the body, or at least has a team of people around them that understands different systems of the body and how they interrelate. And really learning how to get out of pain and being willing to make the necessary changes in order for that to happen. And also not to think this is going to be a quick fix, this is going to be a couple of sessions, someone's going to, click me here and click me there and it's going to be all fine, or someone's going to cut me open and cut something out, stitch me up and I'm going to be fine. It's a little bit of a mindset change that the person that in pain is the person that's responsible for the result, but they probably just need to find the right person or people to help them get there. Would that be fair?
Yeah, I think so. And also the pain has a purpose. The pain is there, generally speaking, to alert you to something. And if, in the first instance, it's typically an acute, let's say a real acute thing, like you break your arm, and of course you've got a lot of pain. Well, that's telling you not to move the arm because it's broken, right? Or you sprain your ankle. Probably more people can relate to that. And, again, it's extremely painful. You don't want to put any weight on it because you'll damage it more if you do. So it has a function in that situation. But if it turns into a persistent pain problem, it also has a function. And this is where I think sometimes pain scientists think that, oh, this is a dysfunction in the system, it's a misfiring, it's a something's gone wrong, and that's why you're still feeling pain. But generally speaking, what it is it's that, there'll be various things in the process that you've gone through which are suboptimal. So maybe you didn't get an effective rehabilitation program. Maybe you just had some treatment which helped you get through the acute phase, but you weren't given exercises to actually pump that area and actually increase the proprioception in that area and build the strength back and the coordination and so on. So maybe that's the message behind it. Another message might be that you're still eating those foods that inflame your system. And that's why you haven't recovered compared to the other people that sprain their ankle that same day. You might have 10 people sprain their ankle on the same day in the same hospital, and 9 of them recover, but that last one doesn't. Why don't they recover? Well, maybe they're eating the wrong foods. Maybe they've got a gut issue, so they can't actually absorb the foods that they're eating. Okay, maybe they're so stressed with an emotional situation that their body has such a high cortisol output, which is the stress hormone, that they can't heal because they've got cortisol overloads. And so, there's many different reasons why you may not be healing, and there's a lesson behind it for you. The skill of the therapist is to help you to identify what that lesson may be. A highly skilled therapist that has an holistic awareness of all of the factors that may be contributing to perpetual pain or ongoing pain or persistent pain, then they should be able to help you see how the pain is actually a teacher for you, as opposed to it being a pain in the arse, right?
Or wherever the pain may be.
Or wherever it may be, yeah. So, and I think, that is actually also a much more positive mindset, rather than to say, I'm in pain, I'm suffering, and, this is not fair, and, I've done what the doctor said, and whatever it is, to actually say, well, hang on a second, I'm still in pain, so something can't be right. So what's the lesson here? What is the lesson? What am I not doing right? What could I improve on? Who do I need to see to help me understand more about this? If the first doctor can't help, can the second doctor help? If that doctor can't help, should I see someone from a different profession? So, that's the way I would think about pain if you're experiencing it right now.
Awesome. I'm just looking on Facebook to see if there's any questions.
Yeah, sure.
There are a few people on that. There doesn't seem to be any questions.
Okay. Yeah, but we haven't actually asked if people have them, have we? So.
Well, I have on Facebook actually.
Oh, you have? Oh, okay. I see.
Yeah.
Oh, you're multitasking.
Yeah, I'm getting in touch with my female side.
Yeah.
There's not any questions on the webinar or on Facebook.
Okay. Well, I guess it'll stay on Facebook, won't it? So people can always put questions underneath, and we can respond by text.
It'll be up on YouTube as well.
Yeah. Okay. Perfect. So certainly, we'll do our best to get back to you. All good.
Well, that's pretty much all I wanted to ask you today, Matt. So thanks very much for joining me and sharing your knowledge with everybody out there who's in pain. So hopefully we can help a few people out there. For me, it's really important for people in pain to kind of change the mindset around pain.
Yeah.
I think that's really important.
Well, I think one of the things that hopefully we're offering by talking about it is that there's really some hope, because I think one of the things that people lose quite quickly is hope, particularly, if you've got a really nice therapist. A lot of therapists are in it because they want to help people. So they're really nice and they're really trying to help, but perhaps, whatever they're doing for whatever reason just isn't cutting the mustard, so you're going to have to change, or stay in your pain state. And so I think a lot of patients or clients or people with experiencing pain, they feel loyal to the practitioner, so they don't want to go off and see someone else. But they also feel like, well, this guy is so nice, or this girl's so nice, I don't want to go and see someone else, because they feel comfortable with that person. They've built that rapport, they've built the relationship. And that's totally understandable, but sometimes you need, a change in mindset, as you say, or a change in approach that can really provide a different perspective on it. And I think the message that I'd like to convey really is that I think there's hope for everyone that's experiencing pain. It's just really identifying what are the triggers and how can we most effectively work with them. And, that's no easy task. So it's not to say that we've got all the answers and can just sort it straight away, because it's not really the practitioner's thing to sort. The practitioner is there to act as a guide and to provide knowledge and to provide information and methodologies and so on that help people to make the changes that bit by bit should just unload the system a little bit more and unload it a bit more. And gradually, if you think you've got a threshold above which you feel pain, well, a lot of persistent pain patients, they're right up here somewhere, they're right up high. And so what we have to do is unpick it. And your well-meaning therapist might have improved your biomechanics and brought you down to here. So your pain level may just have dropped a little bit, but you're still in a lot of pain. So then you might need a bit of nutrition. You might need a bit of emotional coaching. You might need a great exercise program. You might need to take part in meditation, and you might need to get hydrated, and you might need to sleep better. And gradually, when you drop below that threshold, at that point, that's when the pain is gone. But, often it is a multimodal or holistic style approach. That's kind of the reciprocal approach to what the British cycling team have done with their, what do they call it, marginal gains. So if you can just get a marginal gain here and a marginal gain there, and you build it up and up and up and up, lots of little marginal gains, then the end result is you get a macro gain. And so we're doing the opposite in reverse, in a way that we're trying to get a marginal reduction in pain, a marginal improvement in health, a marginal here, marginal there, and eventually you get to a point where you've got a macro change in the body, and the pain stops, and the health returns, and the function returns, and the performance returns, and so on. So that's really the goal.
Awesome. Actually, Matt, I've got one more question for you.
Okay.
So I can imagine there'll be a few people watching this, and they're in pain. And they're probably thinking, from what you've just said, I need to do some different kind of exercise. I need to eat differently. I probably need to drink differently. Life's going to be boring. Or they might be thinking, oh God, this is just going to be too much like hard work. What would be your answer if people are thinking that at the moment?
Well, there's two ways you could go with it. You could go the kind of what would it be, like a martial arts grandmaster who gives you sort of a slap across the cheek and says, this is what you have to do, right? You have to take this seriously. You have to take responsibility. Or you can take the more nurturing approach, which is say, okay, if that's too much for you, then let's work one thing at a time. Let's work out what the priorities are here for you, and let's just start simply. And for some of my patients that are struggling the most in their lives, perhaps with something like chronic fatigue syndrome, sometimes the simplest things can have the profoundest effect. So just for example, most people in modern society don't get outside in the sunlight enough. They don't get into a forest as regularly as they should do. They don't go barefoot on the ground as much as they should do. And they're stuck in electrically circuited rooms with high flicker rate screens that's impairing their melatonin production, that's disrupting their circadian cycles, etc., etc. And just to get them to go, okay, let's turn off the screens from 9 p.m. or whatever it is, and let's get outside, get barefoot on the ground, and just spend some time relaxing in the moonlight. Okay, do that in the evening. In the morning, before you get your breakfast, I want you to get outside, barefoot on the ground, watch the sunrise. Okay, get into the forest, feel the textures under your feet. something as simple as that can make a huge difference to people's pain levels, their energy levels, even though it's seemingly, in a medical kind of framework, that would be seemingly ridiculous. But it's so far removed from where we find ourselves, yet so close to what we were designed for, and all of the systems of the body, the hormonal systems of the body, the electrical systems of the body, which includes, of course, the nervous system, and that controls everything in the body. These things are, and the respiratory system, there's phytochemicals that you get when you go into a forest, for example, which are really, they help to reduce cortisol, which is, part of the reason you're feeling pain, is have high cortisol levels, and they improve your immune function. So, there's all kinds of incredible benefits if we can just get a little bit closer to nature and, try and step out of the kind of rat race environment, very yang environment that we live in. So, really, I guess my point is that sometimes simple changes that are consistent can have profound effects. So you can go step by step, and gradually, as your energy improves, you have the energy to then make a nutritional change, just one change maybe. And then when you feel better because of that, then you can make the change with your hydration, and now you're feeling better again. So now you feel like exercising. And so then, so it can become a virtuous cycle.
Awesome.
I think that's what I'd say.
Yeah, it's just gone a bit slow.
I've lost you. Okay.
Yeah, I think we just lost connection for a moment there. Okay, awesome, Matt. Absolutely fantastic. Now, how can people get in contact with you?
Yeah, they can get in touch with me. Obviously, we're on Facebook, so they can look me up as MatthewWallden.com. It's 2 T's and 2 L's. So Matt Wallden. So yeah, have a look there, and there's contact details on the site. And yeah, those are the best 2 places, I'd say.
Awesome. If anyone wants to contact me, they can at info@bodycheck, that's chek.co.uk. Any final words before we wrap up?
Well, if you say final words, they've got to be profound, haven't they?
Like Jerry Springer.
That's it. Yeah. Well, I mean, I can't remember if I said it on the last webinar, but really, responsibility is the key thing for people that are in pain. Taking responsibility, and really, the coach's role is to help the client to take responsibility and to literally give them the ability to respond. So to literally give them the ability to understand what their health is being stressed by. And so, to give you the ability to get to bed sooner and to get to sleep properly. So there's a bit of coaching that needs to be done around that, to be able to eat better and to eat more to the kind of nutrition that your body needs as an individual. All of these things require a coach with some degree of skill and awareness of these factors. And so, I think you need to find someone who's got more of a coaching model than a treatment model, and that is going to help you to take responsibility for yourself. And that would be the key place to start.
Awesome. Great final words. And I just want to say, anyone watching this, if you know someone else that's in pain, feel free to share this video with them as well. And if they haven't seen part 1 of this, check out part 1 as well. So I'll put links in the comments to part 1 as well, and I'll put links into where you can contact Matt or myself. But Matt, thanks again, and we'll probably do this again sometime.
Yeah, that would be good. Thanks very much, Lee. I'll catch you soon.
Bye, everyone.
Take care. Bye.